Fine, thank you, teacher. How are you?
Not bad, not bad. I'm sorry for delay. I just had one patient that was emergency, but I think 8 minutes is not a great problem. Okay.
Yeah, it's okay.
So today is the second lesson that we plan to do within this 5 days period of time. And today I would like to talk about the topic that might be quite interesting for the students of dental faculty, because we're going to talk about dental implantology and dental implant placement. Yesterday we had a short discussion in preprosthetic surgery, and we identified that in some particular cases, especially when we are facing with the secondary adentia, the application, the implementation of total removable prosthesis is only one way out. But last 30, 40 years in my clinical practice, at least in our country, the dental implants became the treatment of choice. And recently, the success rate of the dental implant placement raised up to 95, 98%. That makes this kind of the treatment probably the best way out how to manage total partial adentia. Well, I will not talk about the history of dental implants because we're going to have a lecture where just right now we are working with the let me say so-called recordings of the lectures that will be provided, I think, on YouTube, and you will get all the comprehensive information about the history of dental implants, the mechanical features, the biological features, the phenomenon of osseointegration. But today I would like to talk about the practical things that might be applicated in your daily clinical practice. Well, first of all, I'd like to talk about the components of the dental implant, as you can find it on this picture. Well, we have to accept the dental implant as artificial root, yeah, that might be placed in inside the alveolar ridge, inside the alveolar process, to restore the root anatomy, and by that being a starting point for the crown restoration. So the dental implant, even it will be placed inside a bone, could be also recognized as a somehow prosthesis. We have a lot of, let me say, types of dental implants. There might be a screw type endosseous implants. There might be subperiosteal implants. There might be so-called plate type implants. But today we're accepting the most successful, most, let me say, acceptable type of dental implant, which is a screw type, which is the endosseous type, and which is now, again, in 80% of cases, we're going to use the implant that will be composed from several components. So the first, maybe the most important and most expensive part of this total, let me say, device, total, how to say, mechanical construction is the dental implant itself. It is usually a cylinder-like or cone-shaped screw-like device that will be inserted, or let me say, screwed inside the bone. Okay. when we're looking to the dental implant as a prosthodontic device, we have to talk about abutment. That is a kind of transmission part in between dental implant and artificial crown. And this abutment usually will be fixed by internal screw. Well, it is very important to understand that here within the dental implant, we have external threads and internal threads for internal screw. Yeah. So abutment will be fixed mechanically inside into the dental implant by the means of the screw. And thereafter, you can place your crown restoration that might be whatever. I mean, might be metallic ceramic restoration, it might be zirconium restoration, might be a pressed ceramic restoration. It's up to you. But before placing the, let me say, the abutment, we have to pass through several surgical steps. And here, within the surgical steps, on the first step, we're using a covering screw that will cover internal threads in order to prevent any soft or hard tissue to grow inside a dental implant. And we're going to use the healing cups that will be used on the second surgical step in order to form the gingiva around the dental implant and make it more or less similar that we do have with the normal teeth. Okay. What about the material which is useful for the dental implants? Again, I will not talk about the history a lot because we passed through the years of development, and within these years we had stainless steel, we had molybdenum chrome alloy, we had gold, silver, platinum, Vitalium, and so on and so on. But nowadays, the most appropriate material that should be used for the dental implants is pure titanium. And the pure titanium means that it is 99.78% of titanium. It is really pure. It's nearly 100%. Yeah. But actually, this titanium, when it's exposed to air, will form a very thick oxide layer, yeah, which is titanium oxide, and this layer is bioinert. Well, one of the, again, that will be discussed on the lecture, but just few words. One of the most important things that should be take into account once you'd like to create a dental implant is that your implant should be absolutely bioinert to the body. There should not be any devastating reactions in between the dental implants and the bone. This is the only one way how to achieve good stability for the long period of time. At the same time, the dental implants will undergo mechanical loading that is the result of the mastication process. So mechanical features of the dental implants is very important. Again, on the lecture, I'm going to explain you what kind of the complication might occur. And believe me, in my clinical practice, I'm frequently I'm facing with the complications that are the complication that is related with the mechanical features, poor mechanical features of the dental implants, like the fracture of the neck of the implant, or fracture of internal screw, or fracture of implant at all. So why we are discussing this so much, why it is important. I think that we have more than 1,000 manufacturers that might provide us by the dental implants, and the prices are different. And that is the key point, because if you will choose a relatively cheap implant, you might face with this kind of mechanical or biological complications. Of course, the most expensive one nowadays, it is Straumann company, will show the most, let me say, the very high success rate of the dental implantation. But the expensive implant means that the price for your surgery and your further prosthodontic rehabilitation will also increase. Well, what I'm doing in my praxis, I've just tried and I did it. I found the something in between. It's a kind of the balance of quality and the price. And last, I think 3 or 4 years, I'm using South Korea production. It's very nice. I really like their design and the post-operative results. And up to now, I think that the number of implants that actually failed was 10, not more. 3 years period of time. The implant is not just a screw that might be screwed into the wood or into the wall. It's not just mechanical, let me say, device that will hold all this loading. Permanent loading by the mastication process will lead to, let me say, micro movements of any simple screw. Well, in maxillofacial surgery, we're using titanium mini plates and screws for osteosynthesis. Once we're just managing the jaw fractures, or we can use reconstruction plates and screws for the management of defects of the mandible. But there are the surface of that screws are completely smooth. They might be inserted. They will not provide the body by any biological reaction, but they might be unscrewed. As opposed to that, we suspect we're waiting dental implants to be stable for very long periods of time. Well, usually, once we talk about dental implant, we have to talk about up to the end of the life. Yeah. Therefore, it should integrate with the bone. And if this implant will be completely smooth, yeah, it will not integrate. Today, the implants, the dental implants, have a special, let me say, covering, or let me say, a special design of their surface. So their surface is irregular on microscopic level. As you can see on this picture, it's not smooth. It's pretty irregular, and this allows the bone to grow inside these microscopic pores to hold the dental implant much more effective. Now, if you're planning to unscrew dental implant, believe me, successful implant that is integrated with the bone, it's very difficult to unscrew this implant. It's not difficult. It is nearly impossible. For that, we're using special devices that will cut out the dental implant and surround bone. What about the types of the implants? Well, here I'm just showing you the two types that is, again, very frequently used in clinical practice. This is a screw type, like, and it has external threads, yeah, for the better contact, for the better integration of the implant with the bone, and creation of primary mechanical stability. Well, the primary mechanical stability means that implant is strong enough within the bone. That allows the bone to underwent several biological steps. Like, if you remember, we talk about the wound healing process, yeah? So it was consist from several steps, 4 steps, basically. That is for the soft tissue. The same is for the bone. So we need some time to let the wound, the bone wound, to be healed. Yeah, so that threads will create primary mechanical stability, and this design is more or less, let me say, a frequent design. Or in the past, well, actually, I have to tell you that was in end of 20th century, beginning of 21st century, cylinder implant that was just, inserted into the bone by the means of the pressure. That was the reason why they do have primary mechanical stability, and they had this kind of the holes on the side, so a bone can grow inside the holes. And but nowadays we're not using this kind of the implants too much, because they might have a lot of problems. Like, for example, if any mechanical problem will occur with that implant, like, and you should remove that implant, for sure you have to cut it out. Yeah, so you have to destroy the bone, then you have to wait for the 2 or 3 months, then probably you might place another dental implant. With the screw type of implants, by the application, just recently we had a special instrumentation set that in 85% of cases gave a possibility to unscrew the implant by the means of excess loading. So that is possible. That's what I'm doing, even for very, very strong. But sometimes you have to cut it out. Okay, so we'll talk about dental implants. We'll talk about the very, very basic knowledge. I mean, we can talk about that for the hours or maybe for the days, because we have a lot of types. We have bioactive implants. We have bio-combined implants. We have bio-inert implants. They might have, and yes, that's what I have to tell you. There's 2 main parameters that should be taken into account once you're doing a dental implant insertion. It's the length of the implant, and it is diameter of the implant. Yeah. So usually the diameter and the length will be calculated in millimeters, and usually we have implants which length is starting from 6 millimeter length up to 16. Yeah. In very rare cases, in very specific manufacturers, we might have implants that length, normal dental implant, that length is 18, 20, 22. Yeah. There's specific systems that should not be discussed today, that should be discussed on your 5th year of your education. It is all in 4 concepts, and it is zygoma implants that is long enough. Like, for example, the length of zygoma implant is maximum length is 53 millimeters. It's a really long implant like this, because it should be placed here in zygomal bone. And the length of the Owen-4 concept, maximum length, I think that is 24 millimeters, because it should be placed like this, oblique, not perpendicular. But usually, minimum is 6, maximum is 16. What about the diameter? Well, the external diameter of standard implant is 3.3 millimeter. In some specific systems, you might find the implant that's diameter is 3 millimeter, or even less, 2.7. But this 3 and 2.7, we don't like it. We don't like it because it's really easy to place this kind of the implant into the narrow bone, narrow alveolar ridge for the surgeon. So you should not do any bone grafting, any bone splitting, and anything. You just have to drill it and place the implant, and that's it. But you should think about future. You should think about your prosthodontic rehabilitation. And that is the key, because as narrow implant is, as more mechanical problems might occur later on, like a fracture of internal screw, like a fracture of the neck of the implant. So that kind of the implants usually 3.0 diameter is a single step implants that do not have internal screw and that should be loaded at once. Yeah. But again, I have experience, I think that this is experience more than 15 years with that kind of the implants. I don't like it. I'm not using this kind of the implants. It's better to use a bone grafting. It's better to place implants deeper. Yeah. But I'd like to avoid of that kind of the implants. The maximum diameter of dental implants in most implant system is 6 millimeter. Yeah, this is maximum diameter. Usually, the standard for the implants is 3.5, 3.75, 4.0, 4.2 in diameter, and the length in between 10 to 13 millimeters. This is the most useful kind of the dental implants in a daily clinical practice. And that is also very important. You see, when you're doing surgical procedure, you have to be ready for everything. You have to have a set of instrumentation. You have to have maybe anesthesiological background, yeah, emergency kit, anesthetics, electrocautery, and you have to have enough number of the dental implants. Because once you expose the bone and you plan to place like 3.75, 13 millimeters length, and you find the bone to be let me say, the quality of the bone is not acceptable, you have to step into another diameter and the length. And if you don't have a stock, if you don't have minimum stock, you'll be in trouble. Of course, you can call to the company, just bring me this kind of the implant, but that will take time. And your anesthesia, your IV sedation will disappear. So you have to form minimal stock in your office theater. And daily, once you're placing dental implants, you have to calculate how many of implants are in your stock and make additional order. Yeah, that's what we're doing in our clinic. That's the only, in my opinion, that's the only way out. I know, well, I'm familiar with some colleagues, let me say like this, that are doing dental implant placement. They are planning to do 3 dental implants, and they have only 3 dental implants in their pockets. And very frequently they are in trouble during the surgical procedure. So they are placing improper diameter, improper length, making a lot of complications. They are losing their patients. The stock is one thing, is something very important. Okay, we'll talk about the dental implants, but it is not just procedure. That's general aim is to screw something into to somewhere. Yeah, it is a treatment. It is a surgical procedure. So before doing your surgical procedure, you have to do the most important thing. You have to establish diagnosis. You have to make your clinical investigation first. That's very important, because if you are starting with the radiological investigation and you don't look into the oral cavity of the patient, again, very frequently you might be in trouble. As you remember, I'm always repeating this during the lectures, clinical lessons, within private conversations. First, you have to do clinical investigation. You have to check the status, dental status. You have to check the status of the oral mucosa, of the gums. You have to make palpation of the alveolar crest that is now edentulose. Yeah. You have to check the TMJ. You have to check occlusion. You have to do complete dental clinical investigation, and only after that you're doing your radiological investigation. Now, radiological investigation, usually what we're using in our clinical practice, it is minimum is OPG. Well, frankly speaking, I'm working in this implant industry for the last maybe 15, 16 years. And I was trained at that time. We do not have cone beam CT scanners in our country. So I was trained by the means of the OPG, and up to date, I'm using OPG mostly. Because I'm doing a kind of the combination of my clinical experience and the radiological data. So when you're making the diagnosis or for the adentia, I think that you can simultaneously pre-plan your surgical procedure. And here, within your surgical procedure, there are two main factors that should be taken into account. First, the site of insertion, yeah, where to insert and how to insert. Like if you're going to look at this picture, here we have the site of adentia, and here I already placed a kind of virtual dental implant here, so it might be placed easily. There's no it is not necessary to do any additional procedures. Most probably, I don't remember this patient, but I think that it must probably, there was no problem with the gingiva, so it will be very easy to place implant here. But on the opposite side, if you're going to look here, the tooth number 25, the crown is completely destroyed, and I don't really believe that anyone can make kind of the crown restoration. So additional implant could be placed here because adjacent teeth are intact. And yeah, of course, that's a kind of alternatives. You might use a bridge reconstruction here, so that teeth should be most probably devitalized. It should undergo the root channel treatment, and then you have to prepare the teeth. You can place your bridge construction, but you will sacrifice two healthy teeth And total price for that will be not too much differ from the price that might be done for the single dental implant placement. So first, what you're doing within your surgical planning, your planning is it procedure that is associated with a tooth extraction or root extraction, or it is just clear dental implant insertion. Another very important thing is that you have to understand that this system, this side is surrounded by vital anatomical structures. Yeah. So that structure should not be damaged during your procedure, and in order to avoid it, you have to trace the structures on X-ray. So I did the tracing of inferior alveolar nerve here, so you can compare it with the opposite side. As you can see, here's the nerve. Sometimes OPG will give like a kind of smoothing picture, so it's not really clear where is the nerve, but in my clinical within my clinical experience, it is here, so I trace it here. And once you trace the nerve, you can measure which length of the implant is acceptable. But with OPG, it is difficult. With OPG, it is dangerous. Why? Because a standard deviation of the OPG in between the patients, in between the different systems, might be raised up to 25%. And that is a problem. That is a problem. In the past, they used special markers that was placed here in occlusion here. So the size of the marker was, it is clear, like this marker is like 5 millimeter in diameter. And once you measure it on OPG, you can understand what length of the implant do you have. Yeah. But nowadays, we have cone beam CT scanner, we have surgical planning systems, and it is very, very precise system. I'm going to show you on the next slide. I just want to finalize this one. And it allows you to pre-plan your surgical procedure, including diameter and the length of the implant, and even prefabrication of the surgical templates, surgical guides. But let us talk about ordinary concepts, yet it is actual. Yeah, you have to trace your anatomy. You have to understand where it is, what it is, and if on the lower jaw it is inferior alveolar nerve. And in simple cases, there is nothing to do with this nerve. On upper jaw, on the maxilla, you have a maxillary sinus. Well, if you're gonna ask me what about this side, what you're gonna do here, I will do a tooth extraction, and I see that there's enough bone here. I think that it is up to 5 millimeters, so I can place long enough implant here without any sinus lift procedure. But sometimes sinus after tooth extraction, which was done a very long period of time ago, you might have the level of the sinus that is here, somewhere here, and there's no enough space, and you don't want to place short implants, especially in posterior maxilla, because here we have extreme loading up to 800 newtons. So what you are doing, you're just making an elevation of the sinus, bottom of the sinus, the mucosa. You're placing the dental implants, and you're placing here the bone grafts. Well, this procedure, according to our educational program, will be discussed on your first year of your education. This is a kind of advanced dental implantology, and it's a little bit difficult to understand all the how to say tricks of this procedure without be educated, but being educated on third year. Two words about 3D CT scan or 3D planning. This is the software that we're using in our clinical practice. It's just a kind of a screenshot. So you might do the combined CT scan, which is which has a relatively less radiation exposure as opposed to a standard multi-slide CT scanner. So we can do that quite frequently, like 2 or 3 months, every 2 or 3 months. So, and its exposure side is very limited. If you need only mandible, you can focalize the CT scanner on the mandible only, and the radiation exposure will be very limited. And nowadays, this kind of the CT scanner are also provided by the virtual planning software. So you can trace the nerve, which will be very precise because you're within the 3D anatomy and you're within the channel. You can place your virtual implants, as you can see here is a 4.0 13 millimeters, 4.0 diameter, 13 millimeters. This is 3.5 diameter, 13 millimeters. And by the combination of intraoral scanner and the CT scanner and your virtual planning, you can prepare this kind of the template, which will show you the direction of your implant that will related with a further prosthodontic rehabilitation. Well, again, that's just 2 words because I can talk about that for hours, maybe for days. That's separated master classes. But now I want to stress you on very basic things related with the dental implant placement. Okay, once you established your diagnosis, you did your pre-planning, right? You did that discussion with the patient. That's very important because patient will choose the type of the implant, the price, the manufacturer, and even the country. That's very important. Well, sometimes I might have the patient that will tell me that, doctor, trust you, which kind of the implant, it's up to you. I just want to have very nice result. But sometimes I have patients who will tell me that, doctor, I would like to have German production only. That's it. Okay? So you have to talk about that before surgical procedure, and it is better to obtain the agreement of the patient for that procedure. It's very also very important. Well, again, I will not talk about preoperative preparations because preoperative preparations are the same. Usually we're using IV sedation, we're using local anesthesia. Now, difference of the local anesthesia once you're doing dental implant placement, that you are not using blocks at all. You see, once the bone loses the tooth, there's no nerve endings inside the bone. So your local anesthesia's aim is to anesthetize mucosa and periosteum only. You should not anesthetize the bone. It's not necessary. Moreover, if you're working with the lower jaw, with the mandible, and you are not doing inferior alveolar nerve block, if you are too close to inferior alveolar nerve, patient will feel that. So this is a kind of an indicator that your implant or your drill is too far or too close to the nerve. Yeah. Therefore, I'm not using any block anesthesia at all. The second very important thing is that dental implantology, dental implant placement requires sterile environment only. it's like you're doing something like a real reconstructive maxillofacial procedure. Yeah. So sterilization is very important. You have to use sterile instruments. You have to use sterile gloves. You have to cover the patient, and you have to use, as you can see, that was discussed. Just a kind of repeating. You have to use scrubbing, and sometimes you have to be completely sterile. It depends on the number of the implants. Well, standard in our clinic, 2 or 3 or 1 or 2 is okay. You can use the gloves only. More than 3, okay, you have to be completely sterile. Your assistants should be completely sterile, because this is a procedure that requires total sterility. Instrumentation. Well, we discussed that I think many times, that we have standard sets for oral cavity, and they are usually more or less the same. They will include some instruments for retraction, for incision, for cutting, for suturing, for subperiosteal separation. But once you're doing implant placement, you need 2 general things. Well, first, it is a set of drills, and the second is a physio dispenser. Well, let us start from the set of the drills. This set of the drills will include the drills with a different diameter. As you can see here, this is like for 3.5, this is for 4.0, 4.5, 5.0, and this is pilot drill. Why do we need this set? And maybe it is also very important to note that you cannot start with 5.0. You always should come from the left to the right, up to the necessary diameter was obtained, because you are doing step-by-step widening of the drill hole. If you will start with this, that will lead to overheating and mechanical stress to the bone, and that will interfere with the biological integration of dental implant with the bone. Another and here we have transfer screws, we have pre-taper, we have countersinks, we have stoppers. And also very important is that every company will provide doctor, with the kit that is fitted, that was designed for their implants. Like this one is Neobiotech. It is South Korea production, and it cannot be used. It cannot be used for the German implants, for example, because they have different, threads design. They have different diameters. They have different protocols. And if you're gonna mix it up, you might face with the great amount of competition. Another very important thing is, that's equipment, that's not an instrument, is a physio dispenser. Well, physio dispenser, as opposed to high-speed handpieces, its maximum RPM will be 20,000. Yeah, it's not air supported. This is electrical handpiece. Yeah, usually it might be this cable could be sterilized, but usually we're covering that by the means of special sheets. Of course, the handpiece itself should be sterilized, and it is provided by a special pump. So this pump will pump the natrium saline solution, 0.9 saline solution, to cool down the drills. Yeah, and this saline solution should be absolutely cold. Like you have to store it inside a fridge, and that's very important because normal temperature inside a body is somewhere 37.2, 37.4, something like that, around 37. If the temperature of the bone will increase more than 4 grade celsius, you will face with the necrosis of the bone. Okay? And that will interfere the biological integration of the implant inside the bone. That will be failure. And just imagine that you're making a drill hole by your physio dispenser. The standard rate RPM is like 500, and it is making a drill hole. Of course, here we have overheating. If you will not irrigate it by very cold saline solution, the temperature here, local temperature, will increase and you will face with necrosis. Therefore, the dental implant placement, or let me say, the drilling of the drill hole for the dental implant should be done by physio dispenser only. I will I will tell you some good news that most of the companies, implant companies, they will provide you by this set for free, and sometimes they will provide you by physio dispenser for free as well, because this is a kind of marketing. They just want to more implants to be sold, yeah, more doctors to work with their production, so they can give sometimes fantastic offers. That's what how it looks like. This is, as you can see on this picture, this is a standard set here. This is retraction, anesthesia, scalpel blades. Here we have subperiosteal elevators, curettes, forceps, scissors for sutures, needle holder, standard syringe for the irrigation, like this. And this is implant drills set. And that's the combination that is absolutely necessary for the dental implant placement. We're always doing this, design of our surgical instrumentation table. Okay, the next, and I think that I showed this picture many times, but I would like to repeat it again. The next very important thing is that your OP theater should be organized properly. Yeah, I showed you, I think that was last semester, I showed you how it should looks like, yeah. And usually we're talking about 24 square meters of the OP theater that should have hygienic zone and sterile zone that will be provided by modern, let me say, dental chair that will be provided by good illumination, minimum 300 lux, that will be provided, and that is also very important, by surgical suction, which is strong enough because you're working with the blood, saliva, and saline solution that will irrigate your drills. And usually the composition of the surgical team is like this. Here we have the patient, and believe me, a patient is a part of the team. Otherwise, nothing will work, nothing. Then we've got a surgeon here, we've got assistant, and we have here a surgical nurse. Well, sometimes if you're placing 2 or 3 implants, you really don't need nerve. Yeah, it's not necessary. Or at least I'm doing like that. But again, it's up to you. This zone is sterile, so everything is sterile here. Patient, surgeon, instrumentation, and even the equipment that might be aside. The part of equipment, I'm talking about the handpiece, should be covered by sterile sheets. And here's this hygienic zone, and here in a hygienic zone we have circulating nerve. That for the dental implants, it's very, very actual, because if you're doing any ordinary surgical procedure, I mean, you can predict that you need 15 blades, yeah, as something additional for making incision, and 3 all silk for suturing. That's it. So you can prepare that before procedure, except tooth extraction, or even sometimes tooth extraction you can choose the extraction force before procedure, so you don't need any circulating nerve. But with the dental implants, it's not so. With the dental implants, you can stop here, for example, or here, and a number of dental implants with a different diameter, with a different length. And once you expose the bone, you did your drills, yeah? I use your drills, you create a drill holes for the dental implants. You will ask circulating nerve to open sterile implant and give it to you in sterile fashion, because implants should be transferred from hygienic zone to sterile zone in sterile fashion. Okay, therefore, except patient, you need minimum 3, maximum 4 persons in this room. Okay, 3 if you don't need assistant nerve, 4 if you need assisting nerve, plus circulating nerve. Sometimes you will also have anesthesiologist as an anesthesiological support, or you're doing your procedure under general anesthesia, or you need deep IV sedation. So there will be anesthesiological team. What about the preparations? So the preparations for that kind of the surgery is not differ from the preparations that will be done for surgical tooth extraction, for example. Yeah, you have to start with antibiotic prophylaxis. That's for sure, because the antibiotic prophylaxis prior to the surgery is something very important. And you have this, I think that you have this slide, you have this table, so you can step to your screenshots. Usually we're using corticosteroids, corticosteroids orally, to reduce amount of swelling after surgical procedure, especially when you're facing with the case that requires more than 5-6 implants. That will be a big site of dissection. The dental implant itself will not provide the patient by the swelling. The dissection of the tissue will. So corticosteroids prior to the surgery, day after, and maybe additional 1 day. Yeah. We are using, it depends. If you need IV sedation, you're doing IV sedation. If not, but that will be done inside the OP theater, inside this surgical room. We are using oral irrigations by the means of the chlordexidine antiseptic solution. And for the dental implants, additionally, we are using the disinfection of the face, because your sterile gloves will touch the face, and if it is not disinfected, I'm not talking about sterility, it could not be sterile, it's not possible, but it should be disinfected in order to reduce amount of infection and prevent possible inflammatory, complications related with the dental implants. Yeah. So oral irrigation plus disinfection of the face. Well, this procedure, the dental implant placement could be called as clean contaminated. Yeah, because in oral cavity, it is not possible to achieve complete sterility. It's not like if you're doing open heart surgery. Yeah, when you're doing open heart surgery, it should be absolutely sterile. If you're doing total hip prosthesis, orthopedic surgery, should be absolutely sterile. But oral cavity, yeah, clean contaminated. But again, if you don't stress yourself on the asepsis and antisepsis, you might face with the inflammatory changes and the complications that will be related with the inflammation around dental implants. Okay, now I would like to talk about the procedure itself. And believe me, it is very easy. It's more easy than to do a surgical tooth extraction. Believe me, it is so. If it is not related with advanced procedures like sinus lift procedure or bone grafting or any I don't know, soft tissue reconstruction. If you're doing just single or maybe 2 or 3 dental implant placement, it's very easy. Again, we did our elucidation, we did our preparations. We are doing local anesthesia only. Yeah. I'm not talking about sinus lift. I'm not talking about grafting. Yeah. Single dental implant placement. Local anesthesia only. No blocks. Not necessary and even helpful. The procedure, totally the dental implants rehabilitation, or let me say orthopedic rehabilitation supported by on dental implants will consist from 3 main phases. First, surgical phase, when you're placing dental implant inside a bone. Second, surgical phase, when you're doing implant uncovery. And prosthetic phase. That is not my deal. Yeah, I'm not prosthodontist, so I'm working only with the first and second phase only. Yeah. What about the timing? Okay, once the implant is placed inside the bone, I'm talking about conventional and traditional approach. I'm not talking about immediate loading. I'm not talking about SLA active implants. I'm not talking about I don't know, some kind of specific dental implant. I'm talking about standard surgical case. Once you place dental implant, it requires some time to be integrated with the bone. Okay, and we have some standards. For the mandible, this is 3 months. For the maxilla, this is 6 months. That's it. No questions, no discussions. That should be, the patient should be informed prior to the surgery. Okay? So that's the standard. That's what I'm doing in my clinical practice. And believe me, some colleagues, my colleagues, sometimes they are doing uncovery very, very fast, like 1 month or 2 months later on, and they just lost that implants. So the body is the body. If you're waiting more than 3 months for the mandible, more than 6 months for the maxilla, it is good. But if you're doing that very rapidly, it's not good. You might be lucky, yeah? Might be a kind of a fortune, but just make everything standard. Just make everything according to the protocol. Because this protocol was designed according to maybe millions of dental implants that was placed up to date. Okay, let us start step by step. So, first step, we did our anesthesia You can find it here. This is total identity of the maxilla. There's no teeth here. So we are making just local anesthesia here on the vestibular fold. I will not do local anesthesia, infiltrational anesthesia here, because it is ridiculous. So I can do 2 shots here, the greater palatine nerve block, incisional nerve block, and this is only one exception. This is only one exception when we're using our blocks, not because it is necessary, just because it has some sense. Less anesthetic solution, more effect, and less pain, because if you're gonna infiltrate all the way around here, that will be quite painful for the patient. But 2 small shots here and 1 shot here, and a total block for the long period of time. Next, you're doing your incision, and it's very important to understand that your incision should be done just within the mid-center of alveolar crest. You should leave adequate and equivalent amount of the keratinized mucosa on both sides. That's very important. That's very important for the next step, so the second surgical step, and the placing of the healing cup. Once you did your incision, you're using periosteal elevator, and this, by the means of the elevator, you're just making bone exposure, making the elevation of the flap. It might be extended or it might be limited. It depends on the quality of the bone. It depends on your preoperative plan, what you're planning to do. For that kind of the bone, for this particular clinical case, it is enough to expose it in this manner. But one thing is also very important, that when you're gonna screw in your implant, it should not touch the flap. So it's not like doing like that and screw implants by the touching of the flap, through the flap. It's not right. So you have to expose it and expose on the bone, because the first and only one thing that implant should touch is the bone. It's not mucosa, it's not fibrous tissue, it's not granulation tissue, it's the pure, clear bone. That's also very important. Then you are making a kind of the marking. You're using small round bore to mark the places where the implants will be placed. Well, in the past, the colleagues, they use a special designed, not virtual planning, that was just designed according to the plastic cost. They use special templates, so you can make some holes within this template and make a reference, use it as a reference to create final holes, final spots, let me say like that, on the bone by the means of this template. But well, just tell you the truth, I don't like these things. I just like the knowledge of anatomy. I know where should be where should a canine be located, or canine premolars or molars. So I'm doing first projection in maxilla. I'm gonna do. I'm gonna start from canine. If this is totally edentulous maxilla, I'm gonna start from canine, and I'm gonna go back. And another very important thing is that the distance between these holes, the distance between 2 implants, should not be less than 7 millimeters. If you do have tooth, the distance between the initial hole and the lateral aspect of the crown of existing tooth should not be less than 4 millimeters. Okay, so 4 millimeters from the crown of existing tooth and central axis of implant, that is this hole, or the distance between 2 holes, that will indicate the central axis of implant, not less than 7 millimeters. That is very important. That is very important because if you're going to place implant and there will be not enough bone in between implants or in between implant and tooth, there will be no osseointegration and implant might be lost. Well, once you did it, once you indicate the holes, once you indicate the site of the drilling, you are using pilot drill. Well, this pilot drill is more or less the standard within the most of the implant systems. Its diameter is around 2.2 millimeters. It's a standard. It's very quite thin, and its general aim is to determine the length of the implant, not diameter, just the length. Okay, how deep can you place the implant? How long should it be? By the means of this very tiny drill, you're just creating initial hole. You're making a measurement by special instrumentation, which is existing in most of these implant systems. You're making the measurement of the depth. Is it 11.5? Is it 13? Is it 10? Okay, so you're sure, and you're placing parallel pin. Well, parallel pin again is the instrument. It will indicate the direction of the first implant. So the second drill hole could be done absolutely parallel to the first one. The only one aim is like this. Well, the implant should be placed inside the bone as parallel as possible, unless you are using all-in-4 concept. But this is something advanced. We will not discuss this today. Once you did initial holes, once you did initial pilot drilling, you can start with the second, third, fourth, or fifth, if necessary, drills. You will widen the diameter of the drill hole step by step. Like if I'm going to use in this Neobertech system, if I'm going to use pilot drill and I'm planning to place 4.0 diameter, I'm going to do pilot, then 3.5, then 4.0. I will not jump from pilot to the 4.0 because that is something that is related with the violation of the surgical protocol and might be related with the further surgical complications. So step by step, pilot, the next, the next, the next, and the next. It depends on the system you're using. Yeah, in Neobertech 3.5, 4.0, 4.5, 5.0. In MIC it will be 2.0, no 2.2, 2.9, 3.3, 3.75, 4.2, and then 5.0. So as you can see, that's somehow that's different in between systems. And once you obtain this system, once you obtain these implants, you will also be provided by the surgical protocol in written, electronic, or maybe video form. Okay. So you did the holes, you create a holes. Yeah. It looks like this. Yeah. Good. You can use parallel pins. It's opposite side to be sure that everything is a parallel. This what we can call pre-taping. No, I'm sorry, countersinging. Well, countersinging, something is needed for making the cortical part of the bone, as you can see here, a cone shape, to reduce the resistance in the region of the neck of the implant. But for the maxilla, I use it very rare. It should be very tough, very dense bone. And I'm going to talk about classifications. I'm going to talk about of the density of the bone during the lecture. So I'm going to give you all the comprehensive information. But again, the mandible is relatively more dense than the maxilla. On the mandible, I'm using this contrasting very frequently. On the maxilla, very rare. Well, sometimes if the bone is strong enough, and not only in the region of the cortical plate here, but also inside, you need pre-taping. Well, for the pre-taping, you're using very strong, very tough stainless steel bore with a very low RPM, like 20, 70, something like that, to create internal threads. Yeah, so these internal threads will be fitted to the threads of the dental implant. The aim is the same. You just want to release the dental implant from additional unnecessary mechanical loading. Okay, but again, for the maxilla, very rare. For the mandible, sometimes. And finally, you're taking your dental implant with the appropriate length and appropriate diameter. You can use handpiece. You can do this manually. You can use special ratchets. This is a special device. And you're just making very soft, very careful insertion of the dental implant into the bone. You should not how to say, be very careful with the implant. You should be very careful with the bone. The implant is titanium. It's very strong material, and in 99% of cases, nothing will happen from a mechanical point of view. But the bone is something living. It's a biological structure, and you have to be very careful with the bone. Well, once the implants are placed, as we discussed that in the beginning of this presentation, we have internal threads, we have internal channel for the further orthopedic rehabilitation, for the further abutments. And it is possible that the tissue, the bone or soft tissue, will grow inside and will block that threads, and we don't need it. For that, we're using a special covering screw like this. Just cover the internal channel of the implant and leave it like it is. What else? What next? Just suturing. For making our suturing. And again, on the maxilla, I like it very much. I like to place a continuous locking suture. It works well on the maxilla. Perfect results, usually no complications, and it's very comfortable for the patients. That also very important, because the number of the knots is just 1 and 2, as opposed to multiply knots with the interrapid with the simple suture. When we have multiply knots here, and it makes patients daily life awful. So I like it on maxilla, but I don't like it on mandible, because on mandible there's a very small chance that your implant is too deep and it's interfere with the inferior alveolar nerve. So if the day after on your checkup you find that there's a numbness here, you have to unscrew your implant at least 1 or 2 steps, or 1 or 2 threads. And if you place this kind of the suture, you have to remove it completely, do unscrewing, and then replace it again. And that is just a little bit less by the time and anesthesia as the initial procedure. But if you're placing simple interrupted sutures, you can release on the one suture only, do your unscrew, and maybe just leave it like it is. Don't place any suture, or place single suture. That's something different. Okay, now we did recheck. We did a checkup of the patient day after. Again, critical point for the mandible is a numbness here. If there is no numbness, that's okay. On the maxilla, it might be related with the perforation of the sinus. And you have to do postoperative OPG, at least postoperative OPG, to be sure that your implant is not the half of the length of the implant is not inside the sinus. Otherwise, you have to take it out. Yeah. If there's only one thread, okay. Sometimes it's just, reaction of the mucosa of maxillary sinus. It might be some kind of, few drops of the bleeding from the nose. That's okay. You make up your prescriptions, and usually that's antibiotic therapy. Prophylaxis for the next 5 days. It's oral irrigations by the means of chlorhexidine solution. It's a painkillers. And suture removal, minimum 1 week, but I like to do that 10, 12, or 14 days later. And once you did a suture removal, the wound is okay. You can think about a temporary prosthodontic device, if this is edentulous maxilla or edentulous mandible. If patient insists on that, if not, it is better to avoid it, because this prosthesis might interfere with the osseointegration process, so that's also is not good. And you're waiting 3 months for the mandible and 6 months for the maxilla. Then you have to do, according to our protocol, we're doing OPG again, because we want to know what is the localization of the implant, what is the state of the bone around the implants, and then you are doing uncover procedure. Well, uncover is very simple procedure. I think that a few minutes later, we're going to finish our presentation. I have uncover procedure. I have to uncover 5 dental implants. That was placed 4 months ago on the mandible. It's very simple. Usually we don't need any IV sedation. Usually it depends. If you do uncover 14 or 12 dental implants, I always prefer to do IV sedation. If I have an emotionally unstable patient, I would do IV sedation. If I get a normal patient who is absolutely adequate, I don't need IV sedation. I'm doing local anesthesia only, again, except palatine nerve block, incisional nerve block for the maxilla, and again, not because of importance, but just because that has some sense, to reduce amount of anesthetic solution. Then we're doing incision in the projection of the dental implant, and therefore it's very important to do your initial incision during your first step just within the mid-center, because the second incision should be done absolutely on the same side, because you need, further on, you need keratinized mucosa around the abutment to reestablish anatomy of periodontal pocket. So that's very important. If you slide your incision somewhere into non-keratinized mucosa, somewhere into the cheek or lingual aspect, that will lead further on, that will lead for very serious complications. So you did your incision, you're making exposure, and here it is not necessary to expose the bone completely. You might do very, very limited exposure, as opposed to the exposure that we did for the dental implant placement, because dental implants are there. They are integrated. And everything that will be placed further on is not titanium, it's not integrational material, it's just a screws, and that's it. So you're making unscrewing of internal screw like this. Here's a covering screw, right? So you're clear your, let me say, clean up your internal channel, and then you're placing a healing cup. So that's the healing cup, and the by definition you can understand that the general idea of the healing cup is just let the gingiva to be healed around its healing cup to form a soft tissue channel for the better access for your further prosthodontic rehabilitation, for your further prosthodontic devices. And you're placing a few sutures. Well, yes, for the healing cups, I'm usually placing a few simple interrupted sutures like this. And here is the situation after the placing of the healing cups, and the mucosa seems to be good. Here we still have, as you can see, here's a line here, some adhesion here, some line here. That's still a kind of the regeneration process, but it's not a problem. You can start your prosthodontic rehabilitation. And for this particular case, and that will be discussed, I think, on the lessons of prosthodontic dentistry, because again, that's not my deal. I'm a surgeon, I'm pure surgeon, but I'm let me say familiar with this system. This is Dodo bar system, which is a partially removable prosthesis that is supported on dental implants. As you can see, the palatal aspect of this prosthesis is not exist. So it's more comfortable to the patients, more stable, and with that kind of prosthesis, patients are usually happy. Well, and I think that this is the last slide. Just want to show you what is actually happening on microscopical level. Well, that's the first step. If again, let us jump to the wound healing phases. So the first wound healing, the first phase of the wound healing is when we do have vascular response, and thereafter we have cellular response, and here we have the accumulation of hematoma in between the threads of the dental implant. Then the cellular response will include the neutrophils, macrophages, and leukocytes. But later on, 3 weeks afterwards, the osteoblasts will start to form a spongial bone here that is relatively weak. So 3 weeks is not, therefore 3 weeks is not enough for the loading of dental implant. But after 4 months, or let me say 3-4 months for the mandible, or 6 months for the maxilla, this spongial bone will be replaced by the compact lamellar bone that is the strongest type of the bone. And this will be a key for success of your dental implant placement. But if you did something wrong, if you made a kind of violation of the surgical protocol, like overheating, overloading, like a usage of improper drills, or your implantation is now associated with the infection, here we have failure of osseointegration. As you can see, there's a bone here, there's threads here, and in between we have that will be granulational tissue, or sometimes if the time after first step is more than 2 or 3 months, that will be fibrous tissue. Usually it is painful. Just day before yesterday, I had a case The patient, she was operated in our clinic. They placed very strange kind of the implants in a very strange manner. She had permanent chronic pain in the region of the implant that was placed there. So we did exposure, we removed implant. It was like removable by hand, and we placed additional implants and other implants. She's good now. She's happy because there's no pain anymore, even on that side. And when I did this implant removal, what I found there, I was implant just surrounded by fibrous tissue that was very painful. We did extraction of the implant and soft tissue as well, and she's happy at the moment. So that's it. Thank you very much for your attention. Do you have any questions?
Thank you so much. I must
Thank you so much
for your effort and for your explanation. The presentation was very, very good. But doctor, I'm sorry about that. I had some problem in network connection, and also I think other students may face with this problem. Wouldn't you mind please to give us your record or, your files?
Yeah, that's really helpful.
Our dean, he said that you can demand the material from your teachers, and they may give you. They might give you.
Yeah, that is right. Well, actually, what I'm doing at the moment, I did it yesterday. I did recording of this presentation, and because we were instructed, and well, actually, that was my primary idea, because sometimes students cannot participate the lesson, this kind of online lessons. I will summarize all the recordings. I'm gonna do a kind of, I think, that DVD or something like that, and that will be done not earlier than next Tuesday, because we have 2 more lessons this week, yeah, and 1 lesson on Monday, right?
Yeah.
I'm sorry again, but is it possible to get PDF or PowerPoint files from you? Because as I mentioned before, our dean say that you can demand it from your teacher. If you wouldn't mind, please give us PDF or PowerPoint files.
Yeah, sure, it is possible, but you know what? At the moment, I did a presentation that was mostly pictures, right?
Yeah.
And I did some kind of explanation, right? So it is more logical to have a video file in combination with the presentation.
Yeah, like if it would be like this video that you're recording, it would be really good.
Yeah, so I'm gonna do these recordings. I think that will be done next Tuesday, and I will inform the monitors. I think that one of monitors can visit our clinic and just take this DVD and make some copies or whatever. Okay.
I highly appreciate you, Doctor. Thank you for your kindness. Thank you for your attention. I hope we can, proper good answer with good marks to you. Thank you so much.
You're welcome. See you tomorrow, the same time, maybe plus minus 5 minutes, okay?
All right.
Okay, thank you so much. See you.
You're welcome.
Thank you, teacher.
You're welcome.
Goodbye.
Goodbye.
So do we have to come to lesson tomorrow?
Yes.
Okay. I didn't know that.
No,
so
every day at 12 o'clock, including Monday. Then we are finished.
Okay, teacher.
Okay.
Thank you.
You have a good day.
Thank you. Thank you.
Goodbye. Goodbye.
Goodbye.